Good afternoon. We are on time. May I request Dr. Prafullo Rana to come in the front row? Dr. Prafullo Rana is here. We are going to start our FOTI session, Forum of Opthal Teachers of India session. Convener of the session is Dr. Prafullo Rana. We are very happy to have Dr. Prafullo Rana with us. However, welcome sir, welcome Professor Jiban Singh TTL Bhai, our beloved President of the Forum of Opthal Teachers of India. Along with that, Professor S.S. Pandav Bhai, who is also the President-elect of Forum of Opthal Teachers of India. Let me to start this session, calling upon the chairpersons of this session. Professor H.K. Chaudhary sir from Silchar, Assam is here. No. Professor K.P.S. Malik sir from Meerut. Professor Dadanji Pandey sir from Noida, Delhi. Please to come and take the chair of the chairperson. Professor Bibhuti Sinha from Patna, RIO. Professor T.P. Lahane from Maharashtra. Professor Subhra Sarkar from Kolkata. Professor S.P. Singh from Allahabad Medical College. Professor Gur Satinder Singh from Punjab. Professor Praveen Basist from Delhi. Everybody will come, but it will take some time, I think so. Now, on the moderator's chair, we like to call upon Dr. Mohua Sengupta, please to come over the dais. Professor Sormishta Behra of Sambalpur Medical College, and Professor Mohua Sengupta is from Rampurat Medical College, Bengal, and Professor Rajkumari Vidyanarani from Imphal will be absent today. We are going to start this session. I would like to request the chairperson, Professor D.J. Pandey sir, to tell a couple of lines of introduction before to start our session. The Forum of Opthal Teachers of India. You all know today's discussion will be focused on the proposed modalities in ophthalmology teaching and training in India. In this particular context, I like to remember and like to congratulate and thanks from the core of the heart of all the teachers of ophthalmology of India to Professor Jiban Singh TTL sir for organizing the beautiful 6th annual meeting of Forum of Opthal Teachers of India at Rajendra Prasad Center for Ophthalmic Sciences, New Delhi in the very first week of January, with the participation of more than 300 opthal teachers from all over India. So keeping that in mind, I would like to request Professor Dadanji Pandey sir to give a couple of lines of introduction. Then we will go to the keynote address by Professor TTL sir.
Good evening, everybody. I'm over here. The idea to make this Ophthalmic Teachers Association, and definitely it was a great success at the RP Center 2 months back. And you know, this is the idea to equalize the standard of the medical education in all over the medical colleges of our country. By that idea, this muted this association, and the teachers must be trained, technology must be handed over to the all people, so that our postgraduates should be learned in same line. And this is the idea I muted, and for that I invite Professor Samanta to call TTL Sahab to express his view. Okay.
Good afternoon, friends, and namaskar to all of you. And this is a very important forum where we need to look into what is happening today and how we're going to improve the future of our young generation, building the training area in such a manner where everybody benefits, and that benefit should reflect to this benefit to society also. So today, the responsibility for me to talk something as a teacher, and how should we look into our teaching aspects. What are the basic areas which can improve the or residency or a fellowship programs, so that we do better for the future also. I would like to thank, especially Dr. Samantha for organizing and making this forum, which is so important. Teaching and training is very important. I think not only for a student, for us also, because it's a learning process which should continue, and teacher will remain teacher till he or she is also learning. So that's a very important part. Nobody is perfect, therefore we have to look into whatever theoretical knowledge we acquire or a student acquire, that has to be translated into practical specialists. Therefore, learning and teaching becomes the important bridging part in the process of making people a good ophthalmologist. I would say there are 4 or 5 important areas where teaching has been looked into. We always focus, see how many sessions we have in a surgical training areas. Everything focused on how to do good surgeries. And that's not only important thing. It is to be a good ophthalmologist, you have to be a good clinician first. Unless you can do a good diagnostic, how can we do a good surgery? So these 2 areas, I think we have to form the proper guidelines in a curriculum. What should be the areas of concern? How should they graduate into these steps of a clinical learning? Then how to do a training in a surgical areas. Like one important thing I realized going across the country, thanks to the election, I could go to many places in last few months, and there's a definite areas where the lack is there in the teaching programs. The institution does have a problem, but there are areas in a private sector who are doing wonderfully better than what we think also. So there has to be a good partnership between the government organizations, teaching organization with the private sector also, and that is how we can uplift the entire teaching, which is towards the super specialization. The good teachers are there everywhere, like we all are teachers, our students are also teachers. So their exposure is also very important in all areas. Like suppose you're working in a government institution, this person needs to look into other area also. Like recently I was in a AFMC, which has one of the most disciplined people we can have. And then I realized I was speaking to them, and almost more than 50% of those the senior faculty are trained in our government institutions like PGI Chandigarh and RP Center AIMS. Then they had a point of view. They realized like coming to these government institutions where patients are public makes a huge difference for them. It's a different interaction for them. Otherwise, they don't get to see a normal population of patients there. So that type of interaction is there. So we are already going to have a rotation program of students between AFMC and RP Center, so that they both realize how things are different in these areas also. I have gone through the various organizations, and we have going to accept the Maharashtra Ophthalmic Society, their request for giving some sort of you can say students coming to RP Center observership for 2 weeks. So these are a partnership we have to develop to make them good students, make them understand what is the idea of making a people working together, respect the system and human being also. I think we all pay to Professor L.P. Agarwal as far we are concerned. He was one person who thought about making training in different areas of ophthalmology. He created a department into various specialties, and that became a center. And that is the first concept which is now translated across the world. And that time only we had 18 super specialties areas. Today we are trying to look into other areas, like we are trying to have a clinic for a genetics, clinic for AI based, clinic for telemedicine, clinic for a rare disease. Those are areas we are changing this concept to those areas also. I think our teaching should focus in those areas, so the young generation think in those areas also. So these are 4 or 5 important areas which we talk about. Improving bedside teaching, which has been the right from the Gurukul days, like the teaching used to be, in association with the interaction happening between a student and teacher. That can only happen if you have this system where patients are admitted, you have patients with you, and residents work up your patients, and there is a discussion between themselves as a group discussion. Then your preceptor, maybe a senior resident, looks into those cases, discussion. Next day morning, the faculty takes a round, and this is basically potentially improving the knowledge and the confidence of students, because we say like a student facing the faculty in the rounds like an examination for them every day. If they then understand this, then our clinical teaching becomes better and better. And actually making the plan is also very important. This is what we do in RP Center, improving the bedside skills, procedures, clinical reasoning, and making confidence amongst them also. Today, I think this is a very important slide, the group discussion. If you see now, NEET is one of the major way to get people into a educational system. So if you have a 10 student, they may be from a 10 different places. Some may be from South India, some North India, some East India. They come from different backgrounds, and they are placed in metro cities. This group discussion, making friendship amongst each other, learning from each other, and also bridging the differences which can happen. So we have to build that idea of making people comfortable in that group, and that also is very important. As far as we are concerned, if I see I have to read some technique of, let's presume, how to give an intravitreal injection. If I read the books, it might take me 2-3 days to understand how it is to be given. If I have a group, my senior will immediately tell you do this, and within a minute I'll know how to do it. So this is like a better than Google in that fact. It gives a confidence, my senior does like this, I can do also. While Google will not do that, because it will tell you how to be done, but actually how it is done is by the individual itself. So this is a benefit we looked into. Most importantly, we look for improving the skill, especially facing the public. And if I tell you my own background, when I came, I could not speak a single sentence of English when I joined my medical education. But this group discussion, being together, made me feel confident I can face the public also. So this is what is important in a teaching area, and teacher will be a person who can get their student to come, and that can only happen we appreciate their skill, their knowledge, and especially giving them the importance. Like suppose somebody done a good diagnosis, you should say, okay, very good, today you have done a good job. That type of you can say words does give you and your student thinking they'll do better also in future. Medical record keeping is very, very important area. These are two important areas we are looking for future also, and this is going to be a part of our teaching, because this has to be there. Surgical training area, only thing I like to highlight here is any medical college where postgraduate teaching is be there, you need to have a wet lab training lab in those areas compulsorily now. And in future there will be a dry lab areas also. These two things has to be there in all the colleges. And recently I realized, apart from the goat side training, people demand now simulators. And various RIOs people have requested us to get something for our simulators to be given to all the institutions. I'm working on that. Maybe I can get through the NPCB simulator to all RIOs to begin with. And that is needed. I think we need to work on those areas. This all know how to go through these training areas. A faculty or a teacher would be with the students, explain them in our wet lab areas, see their videos, train them, and making people to understand. I think I'll end this line, the teacher would be such, who learns from his own mistakes or has seen the mistake done by others. So that is also important for students also, because they have an opportunity to see people doing mistakes, and they learn from that, rather than they creating the mistakes. For them, two things are important. One is making them aware things can be done. Second, giving them the infrastructure which needed for them to learn. I think today there is a definite mandate from government side to give an infrastructure to all the institutions where postgraduate teachings are happening, where the super specialist training is happening. If government cannot provide, you have to have a collaboration with other institutions, collaborations with the private sector where things are there. So that has to be looked into. I think that would be the day where our students will have benefited by our approach also. thank you for giving me this opportunity, and thank you all of you. Wish you all the best. Work hard and let your students become our teachers. Thank you.
Thank you, Professor Titiar. It is very great, have given the insight. In our time, it was only the bedside teaching only, and the clinical interest. And definitely it should be revived in the medical curriculum, which is now going out.
I'll call, sir. Sir, the next speaker is Professor Dr. Gunasagar Das, sir. Sir will speak on why I prefer to undertake full-time teachership in a teaching institute.
Respected dignitaries on the dais and my seniors and my friends. First of all, I will give this oral presentation because my pen drive, the materials in my pen drive has been erased due to some reasons. So please excuse me. So why I prefer to be a full-time teacher in a teaching institute. Lord Tennyson says in his famous poem Ulysses, knowledge is like a sinking star beyond the utmost range of human thought. So there is no end to knowledge. In a teaching institute, knowledge, science, technology are in dynamic state, ever growing and advancing to the future. Innovative ideas can be made here and can be made real also. The young brains are clean and receptive. So, imprinting is fine and for a prolonged period. Their training is for the benefit of public at large. A country or society grows by the growth and advancement of education, science and technology. The administration or management only facilitates. One Chanakya trained Chandragupta Maurya to make an unified India. One Aristotle infused the inspiration in Alexander the Great to march forward to conquer the world. In our Sanskrit, Sanskriti, Guru is in the topmost position, even higher than the king. Uddhava says he had 23 gurus to learn from. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Parang Brahma, Tasmai Shri Gurave Namah. Ajnana Timirandhasya Jnananjana Salakaya Chakshu Runmilitam Jena Tasmai Shri Gurave Namah. So, these are the slokas in our Sanskrit, and in Sanskrit Gita also there is one. The Nobel laureate Rabindranath Tagore says in Gitanjali, where the mind is free and the head is held high, not bounded by a narrow domestic wall. Where knowledge is free, to that, O my God, let my country go. In a corporate hospital or private hospital or practice, this freedom to procure knowledge and advance knowledge is not always possible. My father was a primary school teacher, and he and my mother were well known in the locality as Guru Baba and Guru Maj. A teacher remains always young amongst his young students. He never grows old. So, these are the reasons to be a full-time teacher for me in a teaching institute. I am sorry I could not show the different slides.
Message
it was very good.
You got the message.
Thank you, sir.
Next call, sir. Thank you, sir.
Before Professor, so Mr. Madam, we would like to welcome Professor KPS Malik sir as well as Professor TP Lahane sir, the two pillars of two parts of India as professors, and we are really lucky enough this afternoon to get these great people here on the dais as the chairpersons. Thank you sir for your kind presence along with Professor Dadanji Pandey and Professor Satyaprakash Singh sir. Thank you very much.
Good afternoon all. In fact, this topic already my previous two speakers, Dr. Tityal and Dr. Das, they have already mentioned. So there is a sort of overlap and repetitions. And this topic particularly focus on introspection. The people all sitting here are all expert teachers. So what happens over the course of years, what happens sometimes if we just start forgetting or we change our mindset, something else happens. Otherwise for younger teachers, there are lots many things to introspect. So first and foremost is that when I am in the teaching profession, is that my passion? And do I get joy when I impart knowledge to others? So these are the two basic parameters. One has it only then is expected one is in the teaching profession. Then third thing, like, are we well trained to be a teacher? Then we have to introspect, do I effectively teach and practically train my residents? And then do I come down to the level of my residents, JRs, different category of JRs, senior residents or junior colleagues? Then am I maintaining the pace with the advancement in science, technology and methods of teaching, or just passing the time, or just forgot, or just there is no desire to learn? And then do I conduct bedside clinical rounds with residents as a rule? Because of the daycare surgeries as well, nowadays you do not admit the patient, but however in medical institution, some beds should be kept, and the trend of taking rounds with the residents, which will tell us empathy towards patient, how to tackle that they will understand. So bedside clinical rounds are very important. Do I assess my residents on regular periods for their knowledge and skill, or just it's a formality? This is basically introspection for everyone, because there are several things we just carry on the things like, okay, this is to be done, this is to be done, but how much we are passionate? Do I orient and interact with my residents when they join? They have come to a new sphere in ophthalmology, and they just passed MBBS and did internship, which is not done properly by the residents or by the students nowadays. So I mean they are coming to a new area. So am I interacting with them and orienting them? And do I apprise them about working in a new scenario and about ophthalmology curriculum at the beginning of the semester? There are protocols that you have to send the new JRs to different departments for interdepartmental learnings. So am I really exposing them, sending them honestly to different areas, assigned hours to learn radio diagnosis part and pathology part, other things, and research methodologies training session? Are we facilitating them for self-directive learning? Are we genuinely passing them in your exam, or do we just feel that a poor pass percentage will reflect adversely upon us? Or so many residents failed, not passed. Or sometimes it may be that after 6 months we will have to conduct supplementary exam. It's another botheration for us, so just pass them. Of course, some people say that they will learn, they pass them, they will learn throughout life. But then just passing them without their learning will create a slow poisoning. Another very important thing, am I pulling down the PG residents during teaching and training? And simultaneously, this is something like, there are certain, sometimes it happens, sometimes we are criticizing our colleagues in front of the residents. Another something very bad. Am I focused on my clinical work only? Is teaching a secondary task for me? This also happens. So am I exposing my all residents as a protocol to exposing them to all specialized gadgets? Are they getting enough surgical exposure? Am I maintaining the record? Are we maintaining the logbook? Are they maintaining and I'm just checking it? And for those who are head of departments, are they monitoring their learning objectives on a semester-wise basis? For the HODs, do they feel like their postgraduates would be competent enough to work independently after they pass out? So there are few suggestions. A good clinical medical teacher stands upon 3 poles: clinical work, second teaching, and third research skills, research. So we have to prepare training modules, assess them more frequently. And medical institutions need to take steps to reward good teachers and help the not so good teachers by improving through faculty development program. The concept should change from the teacher to that of a facilitator of learning or a motivator. And this teaching and learning should be evidence based. Use of simulation, dry lab, wet lab, technology assisted, like there are various technologies which can assist, like webinars, web resources by AIOS, ICO, all in American Academy, Wills Eye Hospital, animated online resources, tools for online collaboration, tips and tricks for PowerPoint presentation for your residents, and mobile phone app based support. So to the last, we must update ourselves with the advancement of science technology and cope up with the changed culture, attitude and values of new generation. This is also another very important point, because we see that residents threshold has also nowadays decreased. Thank you very much.
So Dr. KPS sir, do you have to say something for
No,
the teachers to learn, sir?
No, mostly people are senior to me, junior to me, and everybody is really, I think, has expressed that we really have to be friends with the students, and being a friend, we have to see also all the time that we have to stare also at them. That if you have not done that, I would not be happy with you.
Yes.
Definitely. And my duty is that I used to believe that what I know, my student should know. If I knew ptosis, my student should know. If I know the squint, he should know. And that is what I mostly did till I was in a colleges like that. That everything I know, I must impart it to my students. And who are interested, they will get it and they will apply themselves. Who are not interested, you can't help really. Some of them you cannot help. That I have seen, Dr. also knows, Dr. Mittal also knows. Someone you cannot teach really. They have come there, they have joined the AIMS Rishikesh, but they don't want to learn. There are many like that.
Yes. Thank you, sir. So next speaker is Dr. Sarita Agarwal. Is she here? No. So we go on to our next lead talk session, that is Surgical Skill Transfer Course, SSTC, Need of the Hour, by Dr. Karamjit Singh.
सबसे जरूरी है, most important.
Very good evening, respected chairpersons and my dear friends. So this is a very important topic on surgical skill transfer, because it is our moral duty to pass the skills, the surgical skills which we know to our residents or to of the trainee surgeons. So we all know that cataract surgery is the most commonly performed operation in the ophthalmology, and we try to teach the cataract surgery, try to pass the skills of cataract surgery to our residents, so that after their residency they can at least do cataract surgery in a better way. So surgical skill transfer from experienced surgeon to the resident is complicated by the fact that the teaching surgeon primarily acts as an observer rather than directly performing the procedure. So in the previous years when we were students, so we are either observing or assisting, or we are performing the surgical steps in supervision of our teachers, but our teachers were only the observers. So why there is SSTC? So there is a need of surgical skill transfer courses. So SSTC offers a systematic training platform for the surgeon in training, that is the trainee surgeons or the residents in cataract surgery and other subspecialties of the ophthalmology. So wet labs and dry labs in the form of simulator trainings are utilized to reduce the learning curve of the surgeon in training. It also establishes tissue awareness, dexterity and muscle memory required to perform each step of the procedure safely. Access to wet lab and simulator environment should be accomplished by establishing a surgical training curriculum in residency programs. So what are the challenges during the training? So there are several important factors which make training and learning cataract surgery challenges and the other surgical procedures for both the attending and the surgeon in training. Performance of successful intraocular surgery demands fine manual skills and in-depth knowledge of the ocular anatomy and a thorough understanding of each surgical principle such as phaco-dynamics, which is the most commonly performed procedure these days. And there are no inconsequential steps in good surgery, and each step of the procedure lies on successful completion of the steps preceding it. So when we were students, so our teacher used to tell us that you master on one step, then go ahead with the other steps. While the resident surgeon is operating, the attending surgeon is primarily an observer with limited ability to intervene and prevent potentially visually devastating complications. In addition, now these days the patient expectations for a good surgical outcome are very high, and there are so many litigations, so many court cases pending in the courts. So these are the few studies done by various authors to assess the performance of the surgeon in training. So in one of the common study by the Rendelman et al., they observed that as the complication rate of cataract surgery, it reduces after the surgeon in training completes approximately 80 surgeries, 80 cataract surgeries. So when we were students, our teachers told us that you first observe 500 cases, then assess 100 cases, then perform one step 100 times each, then only after that you will be able to complete a cataract surgery case. Those were the days. Similarly, in another study, they found that the cataract surgery complication rate is reduced after 75 cases. So these are the few studies. Those were stressing that there is a need of a systematically planned surgical skill transfer courses. So few studies also suggest that complication rate of cataract surgery reduces for the training surgeons than the experienced surgeons, although after performing the surgeries in steps. 1 minute more here. So this is the program that we design in our institution, the wet labs. Now the stress is on competency based curriculum. Competency based surgical curriculum should include a structured wet lab and dry lab during the first year. So during the first year, the resident should know how to clinically examine the case and how to perform some portion of the senior resident cases and formatting feedback immediately after the cases, and like the few steps like capsulorhexis or irrigation aspiration practice that comes in first year and second year also. Now these days the technology is advancing. The virtually reality simulators, Dr. Titial sir told that the simulators play a very important role in surgical training. Use of simulator and surgical environment to practice the steps of phacoemulsification and VR surgeries. And these days few other simulators are available, like simulators for fundus examination, simulators for ROP screening, those are also available. So this simulator training should also be available for the resident training programs. So these are the few simulators. To conclude my talk, strategies for optimizing surgical education will continue to develop as residency program shift to SSTC and competency based programs, and also the simulator based training programs. The current body of literature suggests that residents can safely learn ophthalmic surgery using a number of different instructional techniques and curriculums. But an organized, systematic approach to surgical education will offer the greatest ability to identify and utilize the evidence-based best practices. So more investigations are needed to understand how the best tailor and instructional approach to the learner to maximize the patient safety and effective skill transfer should be advocated. New advancements in the surgical education such as simulators will be beneficial to the patients, new surgery trainees and experienced surgeons acquiring new skills as the field evolves, although the cost of this technology is very high. So thank you very much for your patience hearing.
Thank you, sir. So we have two discussants, Dr. S.S. Pandav and Dr. R.C. Gupta, to the topic of Dr. Karamjit Singh. Are they here? Yes. Sir, do you want to say something about it?
I think good evening everybody and all the dignitaries on the dais. My namaskar to all the teachers and also in the audience. I think I'll tell you how we go about surgical training. Because surgical training is I have some slides also. Can you put it for me? Surgical training is very unique and very specific because it poses risks to the patient. So if the surgeon is not well aware, and it could harm a person, and the very basis for the medical practice that do no harm first. So no harm first is, I think, is the principle we that follow, and that actually has to be maintained, observed very meticulously, especially in the surgical training, because there the risk of doing harm is maximal. Now, why we need it is because if you look at the scenario, I think this data was collected somewhere in 2006 to 7. I think Dr. Dogra and Dr. Ravi were involved in that. And it was found that they actually inspected a lot of medical colleges in Andhra Pradesh, and it was found that the surgical training infrastructure was, even for infrastructure for ophthalmic training as a whole, and particular surgical training was actually very negligible. And in spite of some institutions having the infrastructure, that was not being put to use. So that was very actually concerning matter. And now if you look at the national curriculum for ophthalmology residency training program, at least because cataract surgery is kind of the main surgery because cataract blindness is still the commonest cause of visual disability in our our country, maybe around 60% or perhaps more. So at least 50 surgeries are recommended to be done by the resident trainee. Higher than this would be preferable. Like Dr. Karamjit said, I think he said that if you go to 75, 80, your actual skill level goes high up, but at least 50 should be there. But are we able to give that much surgery? So I think my own impression is that very few residents actually during their training programs during residency get that much exposure also. And also there's another publication where there are a lot of lacunae have been pointed out in the existing system of training, especially for cataract surgery. And most of our medical colleges are still focused exclusively on small incision cataract surgery, which is not bad because because of the cost involved in it. But I think the other techniques of surgeries, not only cataract but other glaucoma, they also need to be at least be there and taught to students. So there are a number of barriers actually which prevent, and very important thing I said earlier is the risk to the patient, because why I won't give to a surgery to a resident, because I am worried, because the patient can get harmed, and then it will, then you have the medical, legal and other issues that come to you, so you have to deal with them. So, and then also the lack of the trainers, because if you really want to train and then you have to be, you have to know how to train a person. And I think that has been already been alluded to. And also this happens because there's a lack of structured training program. So unless you have a structured training program, you can't just one day ask a resident, okay, come to the theater and do cataract surgery. And that happens many times when the resident doesn't know what the patient is or what his condition is. He has not been involved in the work or the investigation of the patient, and suddenly you can't give cataract surgery to. So it has to be a structured program. And of course, as I mentioned earlier, the infrastructure has to be there. So to get optimal results, you have to have a phase-based training. So you have you give the information, then you have observe the skills, and finally the person should be able to doing the surgery. And cataract surgery or any surgical training is basically, if you want to improve the surgical skills, and if you have a structured program, so it has many advantages because it lowers complication rate, it reduces the learning time, and in that already mentioned the wet labs, phaco trainings, and they are kind of very useful. Now, what with the problem with the SSTs is that they are kind of a for in between. So you go to a conference or attend a special training program, and then you are doing it. That it has its role, but I think to develop that muscle memory, as I think Karamjit also referred to, you need to repeat these tests often enough. So if you're just doing one workshop once in a year, twice in a year, that is not sufficient. That's useful, but it's not actually sufficient to train a person. So therefore, a stepwise approach and on a regular basis is required. So from wet lab to operating room, I think this is again a very good way to expedite surgical proficiency and also decrease complication rate. So this is how we do it in PGI. We actually start from the simulators. They're very expensive machines, but whenever they're possible, I think we could should be used. So our facility is actually open to the resident in our city, basically. So we have a medical college. I think they send their resident to us for the initial training on a simulator. See, here they actually get the hand-eye coordination. The first step is actually the hand-eye coordination. So you have to, and that can be taught very well on a simulator. And once, and there are kind of different levels. So once they have gone through the different levels, they can, do that. The second thing is actually then you have to go through in the gore side where it's animalized. Now there, if you're doing a phaco, so first you have to have hand-eye coordination, then you have to have the foot, hand, and eye coordination. So the actual machine, but an animal eye or an artificial eye, you get to know the feel of the machine, the phaco, how it vibrates, how to handle it, what's the weight of the equipment, and then you have to coordinate with the 2 feet as well as 2 hands and the eye. So it's a very complex procedure. So unless you have that feeling in the kind of an experimental setting, doing straight away on the patient, then it will be difficult. And also by that time, here you learn the different parameters of the phaco machine, as also how to adjust the microscopes. So all that feeling. So when you are finally going to the operation theater, you are very well equipped. You have all the controls with you. You are confident that you can do the surgery. So another important thing is that when you are doing a training program, so training is not just, I think we should also be, the research components should be built into it. So how do we improve our training programs? So unless we analyze our training programs, so I am running a training program ABC, but is it working or is not working? I think that audit also needs to be done simultaneously. And I think when we started this program, we actually had a kind of evaluation system for people who were without the training program earlier and then after that. And we have actually published this data. And it suggests that if you have a structured training program, it actually shortens your training. It reduces the complication rate and actually increases the success rate and the confidence of the students. So thank you very much. So in conclusion, a structured web program is very important in the training for these residents. Thank you very much.
Thank you, sir.
A brief commentary I want to give about the simulators and their cost and all that. Western world like America or something, simulator is must because there are not plenty of patients to be experimented. So they have to go through simulator. In my place, like in Delhi, I know institution simulator crores. And these students don't want to work on it, don't want to learn from this. They want to sit with surgeon, want to get the free hand. Because they don't bother how many complications will happen, because senior will take care when something goes wrong. In fact, I felt the best thing was that our teacher need to be that much committed that he takes the role of mentor, and this student, he sits with him on the table, gives him the step, get up, go to the next step, then sits again. Whenever he comes a mistake, I go to him again that, see beta, I will do this way, this way. I think that helps a lot. Simulators, in a way, it possibly will add to the values. But since we have a lot of patients, and the children are interested that, see, you have done 60, I have not done 40 even. Subharti, I saw that we got patient free for 2 days. So free patients were generally liberty that we can little bit be kind of free with them. And these patients, like I saw to it that every PG by third year got at least 50 independent FACO. But with that, teachers virtually has to sit with the child. Teachers with that.
I think that's very important, sir. I think after they have gone through the hand-eye coordination and
Yes.
eye, foot, and machine coordination,
Yes.
I think the program is, we have a structured program where one table is kept only for the resident surgery, and then every day or on the surgical day, every day actually there's a roster, and that roster mentions the patient, the resident, and the instructor, and the instructor is free during that period of time. So instructor has to be, yes, it is mandatory that he has to be scrubbed. And so the way we look at it is what are the critical steps.
Yes,
so
got
if
to have them.
something goes wrong, then the instructor
Person
has
must
to
take
take
over.
over.
Yes, that's
so because the patient's eye is actually the most important, and I
Because
think, as I
exercise,
said,
etc., you
there's
can
no-
learn on many things.
Yes,
on
yes.
the potato, on tomato, and
Yeah.
anything.
So those
but
coordinations you can
the
develop.
eye of the bakra doesn't do really good. The eye of bakra doesn't
gives
have
you-
good cornea,
Yeah.
doesn't have good lens, and FACO doesn't work on it.
Definitely,
Really.
but it gives you the feeling of
Yes.
that how to make the incision.
The artificial eye is a much
Absolutely,
better
much
process.
better.
That gives you real feeling of cutting the nucleus, real one.
And we have
And made
seen
by
that
this Madhu, our instruments from Delhi only. It's a real good artificial eye. That makes a lot of difference. But anyway, everyone has his own way, and students, if teacher sits with the students, he remembers lifelong that
Yes,
I learned from
absolutely.
him or her.
that still happens, because
Yeah.
after this has gone through, I mean, what we have seen is that the instructor or the teacher takeover rate,
Yeah.
at what point the teacher is taking over
Oh, yeah.
in the surgery, those rates have actually gone much lower,
Lower now,
after
yes.
we started the structured program.
Yes.
Actually, Dr. Pandav,
Yeah.
when we were there in the college as a teacher, every surgeon is having this junior resident, senior resident, like that. 2 or 3 were posted accordingly. And the number one, that was third year student, is always having the right hand of the surgeon.
And in our country,
that's
and
very-
then third year,
that's very
third year,
interesting.
once you leave the
Yeah.
OT, somehow,
Yeah.
leave the OT and some different work.
So that's very interesting, actually.
The second year, we take care of the third year
and
one.
unfortunately in our country, many teachers were not trained. When the FACO
Exactly.
came, many teachers were really not trained.
Yeah, exactly.
So no question of giving FACO because they can't do themselves and they can't teach them. So
So
things
se-
are changing now. Of course, they are
Yeah.
changing very
Since
fast.
that one, sir, actually the second point is what I'm telling, that once the postgraduate after after selection, postgraduate examination, they come to us. The first year for 3 months at least, I rotate everyone to go to the OPD because they don't know the internship, they have not done it. They say to go to OPD, at least syllabus chart, what is the spelling of that one? how to
Retinoscopy
record
नहीं
one.
करते, retinoscopy
नहीं
बिल्कुल नहीं
करते हैं।
सीखते।
नहीं सीखते हैं. So we at least 3 months. They go to the OT. What is the microscope? How many there are bulbs? From where bulb you put the bulb? How you put switch can go? You have to learn everything,
Basic
discipline
everything,
about
machine,
everything.
how to see
In the
it, how
first,
to-
at least after 3 months, then they have to post it in the units.
Yeah,
So that
and
is
as you
the
mentioned,
structure,
I think
sir.
it is also very important because each individual student is different. They have their own characteristics. I think you mentioned of the right hand, the left hand, and when we were going through this program, we realized that some of the students actually, they are doing very well on the wet lab, but when they go to the next steps, there's a problem. Then we realized what is the problem. Then suddenly it happened that those students were actually left-handed surgeons, and we were forcing them to use their right hand.
Exactly.
So we modified our program because the software can be, kind of adjusted, or the position can be adjusted. So we trained them. No, you are left-handed person. You have to be trained on the left hand only. So otherwise we are confusing them. So this actually we wrote it up, and this will be coming in one of the publications. I think maybe a few months down the line we'll have this.
Teaching and training program is always having the teachers who have been trained by the
Because
own.
हमारे देश में ये सोचना चाहिए कि हमारी अपर हाफ ऑफ इंडिया अपने बच्चों को सारों को पास करने के बाद दिल्ली प्रसाद क्यों जाना पड़ता है, मदुरई क्यों जाना पड़ता है,
Exactly.
वहाँ क्यों जाना पड़ता है? What is wrong with Delhi यार? Delhi or anybody else, big city, Kanpur or Meerut or anywhere. Why our children after passing MS has to rush to the south side?
I think the focus is mostly like students, they like to pass the exam, there's their primary focus, and they get like the access to information is easy now. So you can go to the internet, you go to the YouTube and go, you can learn things, but when it's come to doing it, they lack it. And it's not only surgical, it's true even for the other clinical procedures. So I think in this session, so we have actually modified our training program now. So what we do is, instead of having lectures, now we have surgical, like we have surgical training program. Now we have clinical skill development labs. So we have actually shifted to a different, training mode. So what we do is we call a clinical skill development lab. There we are teaching them, like you teach a surgery, we teach them, okay, this is the slit lamp, this is how the parts, how you switch it on, how you clean it up, how all the basic, what are the optics, what are the different ways of examination on slit lamps. Now we are actually running special classes only for this purpose. And then you go to the higher level when they have to discuss a patient using what was taught in the previous week or on the previous days. So then they use it. नहीं, दूसरा हमारा advantage ये भी है कि we kind of fine tune our academic programs, so we are not entirely dependent on NMC, so we have that flexibility. Yeah, that's true. Absolutely. Absolutely, I understand, but the thing is that we kind of trying to create a model, if it works, a few years down the line, so we are also keeping the data alongside that, is there any difference in the new model and the previous model. So if it works, then we will make it public, and then, at least some people can benefit out of this.
Great. One thing I would like to, one important point, most of the time what happens, the resident, they have the curiosity to do the case on the same day. All these days. This is very, very important. How to proceed for that step surgery. Steps are very important. For making a conjunctival, just I am telling you very, very simple, one step, that is conjunctival incision. Like, I am giving example. So first make the perfection of conjunctival. Before that, ask the teacher should ask how to do this particular step. Then ask him to sit down and show me. Like make a small cut and make a triangular, so that after coming, once you be reposited, at this whole wound should be covered. But nobody is taking care that they are making the regular. So the step is very important, that the step surgery. But make the step. Rather, I went somewhere else, though I was knowing everything, all the step in 1995, when I started training for trainer program. So वो जल्दी में, तो इसलिए steps as give 1 step, 2 step, okay, next turn. Go and learn, first read and tell me what are the steps, just enumerate, just tell how we will proceed. Then please sit down, and the teacher is responsible to sit down. This is very important part, the step surgery. Then otherwise if you jump whole step, whole surgery, and once any complaint will happen, it will make a depression to him, and he will start doing the surgery for a week or so.
You lose confidence, and then next time again the same. Yeah.
Next week.
Thank you, sir.
Thank you, sir. Thank you very much.
So our next lead talk is on requisites of an ideal resource center of ophthalmology by Professor Dr. Samanta sir.
चलिए, अंत भला तो सब भला.
Chalo. Hey, slide. Respected chairperson and the honorable delegates present here. My presentation will be very brief because already you have discussed everything. After working in medical college with undergraduate and postgraduate for the last 44 years, I have retired on 1st of January 2024 at the age of 70. So I just like to narrate some my own ideas and what should be the requisites of an ideal resource center of ophthalmology. From centuries back, during the days of Nalanda, during the days of Khajuraho, all these universities, you see, the golden treasure of any teaching institution are the resource centers. They have got their own libraries and everything. That's why I think for proper teaching and training program, there must be a good resource center. So what are the requisites of resource center and why it is required? To collect as well as organize materials, those are useful to a particular group of people. This group of people are nothing but our students, these resource centers. This will provide information to upgrade their education, provide regular assessment assistance, and provide educational service and guidance. Now, what are the resource centers? Number one is a library. This library is most important. This second is the archives, that is a museum or archives. Third is skill transfer labs, what we have already discussed. Fourth is simulation, same thing. And fifth is hand-on course. This library, we all know, is all packed up with printed books, with charts. Now newer addition is e-library along with the copy facilities. Whenever you are in Calcutta, you know Calcutta harbors the ancient library of Indian subcontinent. If you be to the School of Tropical Medicine, Calcutta, you will be surprised to know they have got the books more than 2000 years old with all in these palm leaves and others and written with ink. And in that library, they only allow the researchers to go there with wooden steps. You can go upstairs and you can get all these beautiful books, and where you can find out that Cantharis fly well was used for the treatment of iritis in 10th century or in 7th century with all those. And you can see all those printed in wooden blocks of all beautiful literatures. You can find out that atropine can be used in leprosy patients for as long as 35 to 40 years. All these are there in that School of Tropical Medicine library. So this library is the golden treasure with printed books in different printed forum. Second, charts. You know, for centuries together we can get so many charts, right from the days of Leonardo da Vinci and also back. The charts were found out even on carving as well as so many ancient places in different forum. And latest edition is e-library. E-library is a beautiful thing. The students can access it at any time, but everything requires copywriting, whether a Xerox copy or copying in different forum. Now archives, that is another golden forum. Here in Calcutta, if you have got the time, you can go to the National Library. In National Library, they have, that is the golden treasure of so many beautiful books, models, charts, and model of old instruments even. And in Calcutta Medical College and in different medical college, you can get beautiful archives of model of old instruments. The very first slit lamp, which was invented in the year 1852, that was there in Calcutta Medical College like this, and the xenon arc photocoagulator. These sort of old model instruments are also there in so many institutions. And the evolution of modern ophthalmology, that is not only interesting, that will give you some numerous thoughts to think over for your research work and others. And the most important is the old thesis. I do not know about other universities, but in Calcutta University, you can get old thesis for the last 70, 80 years old. So whenever we ask any student to prepare his dissertation, they can jolly well go to the library and find out so many old theses and can prepare some sort of dissertation by going through 25 years or 50 years back. And lastly, the skill transfer course. You all know the skill transfer course we have already discussed. There is demonstration of the technique, there is self-performance and recording. But the most important, viewing of the performance in leisure hours. What we practiced whenever we were student, the trainees in Arvind Eye Hospital about a quarter of century back. Whatever we used to operate, they used to give us this particular record, and in the evening we have to go through these records in our leisure hours in the library and have to gone through by slow movement and what wrong we have done, so that in the next day we can check and we can refresh ourselves, the critical review, and afterwards the publication. And hand-on course, this has already been discussed by the previous speakers on model eyes, on dead animal's eye, goat's eye, on cadaver eye if possible, on human eye under supervision. And now it is all a debatable chapter. But when we have practiced trabeculectomy operation or other such sort in painful blind eyes when we were students at Calcutta Medical College in 1980s, about 50 years back. But I don't know whether it is practical or not to practice on painful blind eyes. Not. With these few words, I like to initiate this discussion. Thank you very much.
Thank you, sir. So next is my topic. I am Dr. Sarmishtha Behra. I come from Orissa. I work in a medical college as a professor, and I took up this topic to discuss the importance of case discussion on the day of admission after OPD. It sounds very silly because it's only obvious that all the cases should be discussed on the same day. Let me admit, me also, like I have become a professor, so just finish the OPD and go back home, and the next day I expect in the OT everything should be ready. So now these days we cannot give a gap of a day from the day of admission. It's my opinion, seniors are there to decide. A gap of a day probably would give ample time for evaluation of every patient before taking the patient to surgery or to continue with the conservative treatment, because many small things are missed out. Now again, what has happened, maybe I'm wrong, there are ample number of hospitals built only for BSK. In our state we have BSKY, that is Biju Swasthya Kalyan Yojana. So according to that, the government pays 7,725 rupees per FECO patient that is operated. So what is seen is anybody like a non-doctor also builds up a hospital, and they do these surgeries in huge numbers and for the sake of money. So what is happening, the travel fare to the patient is given, and the patient is also given food. So they prefer to go to these hospitals rather than coming to the medical college. So what is happening these days, I was listening to all the discussions, this is my observation, we have very few patients to give hands-on to the students. The patients that come to us do not come primarily, they come to us only as a tertiary center. The complicated ones, they come to us, and very few, a very small fraction of them come to us for primary cataract surgery. So this is the scenario now. So once, and all of you will agree that the patient knows much more than the surgeon. They come up, बाहर तो एक ही दिन में हो जाता है, घर छोड़ देते हैं, it is OPD procedure, why are you admitting us? So that is also one thing. So when a patient comes, my contention is if we give ample time to them and if we evaluate them properly, gain their confidence, gain their faith, and if then we go about it slowly, maybe that will help in all the academics and all the things. And I would not repeat with all my slides because everything is already discussed. And my next speaker is, next discussant is Dr. Sucheta Parija. If anybody wants to say something, sir.
Actually, ma'am, you are very much right. Nowadays, very constrained, no doubt. But I tell you, this is the only the things which we in OPD we admit the patient, and suppose your OPD today,
Yes, sir.
So what I consider in my own time, the OPDs today, definitely I used to see all the admitted patients same day,
Yes.
whether 2:30 or 3:30 or 4. Not only I instruct the residents what to do, like in my as a residency, there was a test bandage. I do not know, most of the people not heard the name of the test bandage. In the PG admission, when I asked what is the test bandage, all the PGs failed. I tell you, a very reputed institute, I will not name. What is the test bandage? Failed. In our time, test bandage just to put the bandage for 24 hours, next day open, if any discharge on the pad, it means the case is infective. They postpone the operation. You know, that is the test bandage. So at that time, we do the test bandage. Later on, it becomes as OPD, the pathology slide. When I become the OT, I am the PG student to the now the HOD, what I started, all the postgraduates, after the admission, everybody has to take out the entire smear on the slide, get the microscope from the pathology department. I got it done, stain it by the GIMSA stain, I just look it, positive or negative. Anybody can do it. And the same resident started seeing the gram positive, negative. And if we feel there is positive, send it for the culture. Postpone the case. Other, with a negative, go for the operation. So that is the way how we have started, you know. And there is very low, I tell you, in the Agra Medical College, we have more than the 30 to 40 doctors, especially having the volume of the surgery there in Allahabad Medical College. He used to operate up to 2:30 in the night, being as a principal. He works as an officer also, academic work plus administrative work, and then the OT. So like that, all the person have independent their own way, how to design their own department, like the family. If you are the guardian of your family, how to run your family. Similarly, the institution, the department, you are HOD, you are the person, to how to run it, you have to develop. Learn from our seniors, learn from the colleagues,
Yes, sir.
and learn from the juniors. Sir.
May I take a kind comment from Professor S.P. Singh, sir, who for the last consecutive 5 years became the highest number of cataract surgeries by the government of Uttar Pradesh, and being a principal and HOD, how he is.
Exactly. So that is, you know, this we have to design.
Sir,
And we have
Yes.
learned,
Yes.
we have learned from our seniors how they have done it,
Yes.
how we should do it, and how, where, and how we can improve ourselves. So this is, you know, yes, Dr. Gupta, another principal of Meerut Medical College, he will share his own experience.
Actually, sir, it's very difficult to comment on this particular issue because it relates to lot of mass ophthalmologists who are not in medical college basically. So what is happening is that 100 patients are getting admitted and in the ward there is no patient. And next day all 100 patients will come, they will get operated, and if something happens, private people will manage by hook and crook, and government people will be caught if something happens. So this is the routine thing which is going on, and we as ophthalmologists ourselves, we are getting ourselves into trouble because we are giving the impression in the society that cataract is a very, very easy operation, no need, no complications. So if there is any complication, society or patient doesn't want to accept it at all. Okay, so there it is far from reality. So that is the thing, and I think as a teachers we should make something like that, because I am for me it is not very much problem because I am an oculoplasty surgeon, and without any exception I admit all the patients. If any patient is not admitted, I will not operate next day. If patient comes on the day of operation, I will not operate. I will refuse, because I operate only those patients who are in the our OT list. So OT list will be only those patients who will be admitted. So I think if not necessarily for all cataract patients, at least some 50%, 60%, so that teaching should not suffer. For the evaluation, pre-operative evaluation should not suffer as far as our PG students are concerned. So this is what I think our job is, So as a FOTI platform, we should do something that how we should have a consensus. We can have a separate meeting or separate discussion on other topic, but this is very, very important.
Your experience, you share.
Thank you so much. This is as the speakers already told about the importance of the admission and evaluation. You know, this is very, very important to investigate. As we know, there is protocol, pre-operative investigation. What are the examination? What should be? What are the reasons that is required? And what are the investigation that should be that also required? So until the person admitted for some time, then it is not possible to investigate, examine completely. And you know, the patient nowadays have very high expectations of related to the vision, quality of the vision. And you know, most of the time it happens that the fundus finding is there, and maybe vision division, vision maybe because of glaucoma, or the any fundus pathology, any changes takes place, or even pre-operative. You know, nowadays it is again very important to manage to know about the pre-existing astigmatism, so that at least the senior science should be aware, and it should be written in the and the protocol should be developed. Like once the person lie down, then at least the surgeon should start asking in few points related with the person, what is the K1, what is the K2, which is steep axis is there, and what is the power. So, and then if you ask what is the fundus finding is there, if in a mature cutter, if you start doing asking these questions, then this become the responsibility of the resident. Now, yes, the surgeon teacher will ask so many these the important questions. So definitely he will come with a paper, and then he will do and they examine the patient thoroughly. And if the any patient K1, K2 is different, how much it is there, whether historic lenses are required, or only can be managed by giving the incision in the steeper axis. If it is more, then you can give some LRI. So this is very important. This is our responsibility. At least we should interact with the student, ask during before, just before operation. Thank you very much.
Madam, please.
A very good afternoon to you all, and I should thank Saman sir, the chairpersons, for giving this opportunity to talk to you. So I'll be talking on importance of bedside teaching during residency. Already we have discussed so much about it, and sir has given why it is important. So I'll just start with the introduction. This was what William Osler said: "He who studies medicine without books sells an uncharted sea, but he who studies medicine without patient doesn't go to sea at all." So this is very apt. And how did this bedside teaching come into the forum? It was Professor Osler. He was one of the 4 founding professors of John Hopkins Hospital, and he is credited for giving the first residency program to bring medical students out of the lecture halls to the bedside for a intensive clinical training. So why this importance is there, and we say that it is dwindling, but actually bedside teaching is a part of the curriculum. Without that, very important, if you don't see the patient, if you don't examine the patient, and if you don't come in touch with the patient, even how much technology comes into being, we cannot come to a particular differential diagnosis. We don't learn certain abilities, and what is that all? Basic things of how to take a history taking, that is very important, the first and foremost. So when you enter a residency program, you should be first and foremost, that sir was talking, 3 months is rotated. So he has to learn the history taking, he has to learn the physical examinations. Examinations may be for ophthalmology, all the things like slit lamp examination, indirect, how to do a fundus examination, how to do it, tonometry, logical reasoning. If you see the patient, then what all things they are seeing, not just the eye, but the systemic things. So a patient who is coming, you are seeing certain pearls in that eye, go for and look for other things. You see a vasculitis in the patient, and then you have to see thoroughly whether he has any other foci of infection in the system. Think that can a chest x-ray be done, or can you put a stato on the patient yourself and to look for certain things. With that develops the clinical diagnosis. You learn how to make differential diagnosis, which is very important. And in the process, you learn a communication skills. That is how you talk to the patient. That is very important. And then slowly you learn what is professionalism. So when basically touch, respect, empathy, this which is very important, and it comes about. So in the process, it means to be a best doctor, which are actually being taught in the process, which we incur, which is not seen tangentially that we are teaching you. So that is what is very important. And then bedside teaching has all these important things which we have been talking about. So what we are talking, that technology is there with us, but this is very, very important. So if you see the routine rounds which they have in the medical college, morning rounds and evening rounds, why I am saying it is important? Because some of the subtle things, a patient who is having a fever and tomorrow you are going to take up for surgery, or a patient who is there with you with a foci of uveitis, it suddenly develops a joint pain and you have missed it in the history taking, but in the evening rounds when you are doing a thorough examination, you come. You tell your own students that what are the things you are going to learn, you are teaching them the things. So not necessary you can have your own plan of action that was being decided, but a bedside teaching or a round is very, very important. So how it will be done, the junior residents, the interns are with you, the senior resident gives a round, then you have allotted your assistant professor, and then grand round is done once in a week with the professors around teaching you all the basic things in the process. So it not only develops your clinical acuity and also what are your surgical complications, but also it helps you your regional thinking and how you manage the cases. So in a patient room we ask certain things. I'm not going into details of this, and it actually helps you to develop your things. So what Jane Rao used to tell, and I remember that very much, in 3H he has taught us. So what are this? Your hands, your heart and your head. So these things in the combination is what is basically a bedside or a clinical teaching, and which is very, very in the and has to be taken for any residency training to train them to be a professional doctors. Thank you.
Thank you very much. It's a very nice comment and observation. Very good. It should be every institution.
And basically, sir, the thing is, it's a system orientation, and if the head is good, they make their own protocol and pro forma, and then it has to be followed. So basically, it is not only the residents at fault, neither the doctors at fault, neither the system is at fault, but who is there can make their own things, and then we go about. So whatever little resources also we have, we can make a very difference. It's your attitude that matters.
Very true. Very true.
Thank you, Dr. Sucheta. So we can have the concluding remarks by Dr. B.N.R. Subudhi, sir.
You all know Professor B.N.R. Subudhi, who is now the Vice President of Forum of Ophthalmic Teachers of India. Before that, he was the Secretary General of Ophthalmic Teachers of India for 3 years. And a genuine, dedicated, sincere teacher for the last 30 years and or more 35 years. From MKCG Medical College, Berhampur, and before that he was also a very meritorious student. Never stood second in his career from matriculation day in Odisha. So
thank you, Dada. To give a brief introduction. So we had a really great discussion with some of the senior professors and so many professors and teachers sitting in front of me. And to summarize what we learned in this 1 hour, so something about the ideal teacher in ophthalmology and ideal setup. Yes, a good teacher and bad setup. If you have no instruments, even a good teacher becomes handicapped and he cannot teach well. A bad teacher and good setup, again same thing happens. A bad teacher, he doesn't know how to handle the instruments and what he can teach. So both are complementary to each other. So a ideal teacher flourishes when he has got everything with him. So of course, what I would say, when we were students, etc., a lot of equipments were not available in the medical colleges. But nowadays, with government's interest and government's has given us a lot of instruments. Even I would really happy to announce that sometimes in a local medical college there are 3 laser instruments, 3 phaco machines. Everything is there nowadays. But only thing, we have to build up a good teacher. As Professor Titial has already said about the bedside teaching, and also Dr. Suchita also told about the bedside teaching is very important. But nowadays, present day circumstances, as one of my colleagues has told that because of this Ayushman Yojana, and although we are in a hurry to finish up the surgical cases to get money. So many of the primary criteria nowadays, and teaching has gone to the back door. Nowadays, recently, many medical colleges, this is the practice going on, to earn money at a short time. In that way, we lose so many things to teach a good, prepare a good student. Nowadays, we are lacking that. And one of my colleagues said, why he became a teacher in the medical college? Yes, teaching is a profession. Many times we are really, when we see our teachers who are teaching us, we feel that yes, once I should also become a good teacher. I must, but are we doing justified when we become a teacher in the medical college? Are we coming regularly to the institution? Many times I've seen some of the medical colleges, the teachers are not in time, they're not sincere in teaching, they're not preparing themselves before coming to the institution. And they've got so many problems with them, so they don't want to teach. So that's why there should be protocol in the college, medical college. Whoever comes to teach a student, he has to follow all these things so that at least we can prepare a good student. So to make a good student, we must have a good teacher also, and teachers also should be up to date in the knowledge. They should have the knowledge and encourage the students to go for the research and public. The teacher should know how to prepare a case sheet, how to prepare a case history. Everything has to be the teacher very good. If he is good, then only can teach the student, and the student will be a good teacher. So that's why many times, even after the completion of 3 years degree course in a medical college, in the postgraduate degree course, the students has to run to the private hospitals, maybe Arminda Hospital, Elpis, because what is there? Why they are different from our medical colleges? But there is a regular protocol is there, then you have to follow that protocol, and automatically you learn within 6 months to 1 year what you have not learned in the medical colleges. There also the same thing, problem, but still then, wow, you become a good surgeon after completing your fellowship, not your postgraduate, whether it's MS or DNB. Yes, SSTC is the need of the hour, surgical skill training, because as everybody has discussed, I don't want to go into the details, but hand and eye training, that's very important. So simulated training is, I've seen the simulated training, I have done also the simulated training in this Help Me See simulator machine in Mumbai, and some of the conferences they have come. They taught us how to make your hand and eye coordination possible, and we have lot of students we sent from our our place to go to the Mumbai Help Me See. They conduct regular programs and this under the simulated training. So this simulated training, it is really very expensive instrument, but it's really useful to the students to learn some basic steps. And of course, once you learn the basic steps, you should have wet lab in all medical colleges. You should have wet lab, and you should get the goat's eye to practice your hands. And as somebody already, Dr. Swapan Shamant told that there are some painful blind eyes. You get a lot of painful cases, or sometimes trauma cases where the eye is lost, where we enucleate. Why not to try in those cases some of the surgical procedures when we make our hands, skilled. So already there are two other topics already discussed by Dr. Behra and Dr. Suchita. This is the importance of bedside teaching and importance of having a good resources in the medical college. And still, in spite of all this, nowadays, in a medical college, I will tell a few examples in our government, in our state. There are number of medical colleges have increased from primarily 3 medical colleges. Now it is about more than 11 medical colleges. The faculties are very, very minimal. We don't have much faculties. And these faculties transfer to the other medical colleges. From the other medical, they come to here. So like this, the faculties are very few. And the students have also been increased number. In a medical college, there were 27 medical post-grad students, and hardly there are 3-4 faculty. There is a disproportionate student-teacher ratio. That is also harmful to the student teaching. So, really, it's a good thing that the FOTI takes up so many issues, and simply sitting here having hardly only 10-15 members doesn't serve our purpose. So, all of us sitting here, please give us a suggestion. We must put it into our people who are doing the formulating the rules and regulations. We have to put to them, either NMC or the head of the institution, or the All India Institute of Medical Sciences. So we have to do something. So sitting here and not in the four walls. It has to come out of the four walls. It has to be given to. So thank you very much for joining in this program. And yes. So thank you once again on behalf of the FOTI. As Dada, I was the last time I was the secretary, recently I have taken the vice president. So I invite all the people to join us in all the 40 sessions in coming future. Thank you very much.
Thank you all. There is some announcement. I would request each and every 40 member that tomorrow and day after tomorrow they should try to motivate at least 5 colleagues of them to be the members of FOTI. The handover ceremony of the presidency will be done in April. The date will be decided. Professor J.S. Titial and Professor S.S. Pandav will be the president of FOTI from 1st of April. And with great pleasure we are announcing that in Chandigarh, the next FOTI meeting will be held under the presidency of Professor S.S. Pandav in the first weekend of January 2025 as per our protocol. So please keep that date free. Thank you very much.
Wait, sir. पीछे पीछे आ जाइए, थोड़ा हो जाने से पीछे आइए सर, थोड़ा पीछे आ जाइए, आपका हाथ आ रहा है, थोड़ा पीछे आइए. हाँ, रेडी. थैंक यू सर. 1B.